Hello, my name's Katie Hannant. I'm the clinical lead for children and young people's asthma in Frimley, and it's a really short webinar today on AIR and MART regimes in childhood asthma. And it's really for clinicians and also for parents, and it's to go through how we in clinic change children over onto we actually change children onto a MART regime rather than an AIR regime. But I will talk about AIR regimes in very briefly as well. So, when we talk about asthma, I don't want to go too much into the details of what asthma is, but we know that asthma is a chronic respiratory condition and it varies from day to day, and it is episodic. So you'll have episodes when your asthma really plays up and you'll have episodes where your asthma is really well controlled. It's the most common chronic condition that children have worldwide, and the symptoms are wheezing, coughing, shortness of breath, and all of those other symptoms that you can associate with asthma. So some children will complain of a tummy ache, or some children just won't be able to keep up with the daily exercise regimes that children tend to have. So we really are looking at children when they're playing with their peers, and are they able to keep up with their peers, and are they coughing in between having a cough or a cold? And that's really sometimes the clinical signs that we look for asthma. But asthma isn't just one particular symptom. We look at a lot of different things to diagnose children with asthma. So this is when you have been given a diagnosis with asthma, and you might go on to the slightly different regimes. So you're usually, when you start your asthma journey as a young child, usually you're started off on a reliever inhaler and also a preventer inhaler. And these, when we're talking about AIR and MART, we're talking about a combined inhaler, which has both of those medications joined in one single inhaler. So when we talk about AIR, it stands for anti-inflammatory reliever, and that is where you've actually got the preventer inhaler and also the reliever inhaler in the same combination in one inhaler that you take. So it's got immediate relief from any symptoms that you've got, but it's also got ongoing properties in it. It's got the ongoing steroid treatment that we want asthmatics to have, which is the anti-inflammatory treatment as well. And in these inhalers, you've got budesonide, which is the steroid, and you've got formoterol, which is the short-acting beta antagonist. So that tended to be the blue inhaler that you would use before. So when you're talking about a MART regime, it's slightly different. So the MART stands for maintenance and reliever therapy, and this is really what we tend to change children onto. So it's the same inhaler that you use daily for your maintenance and also your symptom relief. So it just makes it a bit more simpler, and we tend to change children. It is actually licensed from the age of 6, but we tend to change children onto this type of inhaler, usually as they're coming close to secondary school age. So any child can be changed from the age of 12, but sometimes we do it younger when children are just getting more into just actually being able to cope with handling their own inhalers and carrying their own inhalers themselves. So this is, I'm going to go through quickly just what we would do in clinic. So in clinic, we would always give children and parents, and we would run through their asthma action plan, which is slightly different if you're on a MART, or sometimes it's called a SMART regime, and that's just because it's got Symbicort. So this is the most common inhaler that we use. There's only actually 2 inhalers that are licensed in children as a combined inhaler. So this Symbicort is the one that we generally use in clinic. And I'll just go back to this care plan in a minute. But what we do in clinic is we give children one of these. So this is a demo inhaler, and we give it, you can get these really easily from AstraZeneca, and this is that's who makes this type of Symbicort inhaler. And so we give it to the children, and it just gives them the chance to play around and to see what you need to do to actually get the inhaler prepped. But we always get them to watch this video because we find it really useful. So I'm just going to play this video for you.
Hi, I'm Debbie. I'm an asthma specialist nurse. I'm going to show you how to use a turbohaler. This is a dry powder device, or DPI. Getting your inhaler technique right is very important because it helps you manage symptoms better. It may take a few tries to feel comfortable using your inhaler, but it does get easier with practice. When you first get your turbohaler, you need to get it ready to use. First, twist off the cover and hold the turbohaler upright with a coloured base at the bottom. Turn the coloured base as far as it will go in one direction and then all the way back again. You should hear a click on one of these turns. It doesn't matter which way you turn it first. Repeat this sequence once more. Your turbohaler is now ready to use for the first time. When you use your inhaler again, you don't need to repeat these steps. To use your inhaler, first, twist off the top cover. Check there's nothing inside the mouthpiece. Check the dose counter to make sure the inhaler isn't empty. On some turbohalers, the dose counter is here and shows the number of puffs left. On other turbohalers, the dose counter is here. When there are only 20 doses left in the inhaler, a red strip will appear in the top of the window. When it gets to the bottom of the window, this means your inhaler is empty. Hold the inhaler upright. Turn the coloured base to the right as far as it will go and then to the left until you hear a click. Your dose is now ready. Sit or stand up straight and slightly tilt your chin up as it helps the medicine reach your lungs. The next steps all happen smoothly in one action. Breathe out gently and slowly away from the inhaler until your lungs feel empty and you feel ready to breathe in. Hold the inhaler horizontally, but don't tip it upside down as the powder may fall out. Put your lips around the mouthpiece to make a tight seal. Then breathe in quickly and deeply until your lungs feel full. Take the inhaler out of your mouth and hold your breath up to 10 seconds, or for as long as you comfortably can. Then breathe out gently away from the inhaler. If you've been prescribed a second puff, repeat these steps. When you've finished, twist the cover back on. If you've used an inhaler that contains steroids, rinse your mouth with water and spit it out to reduce the chance of side effects. For more tips on using your inhaler, why not watch our other videos?
So that's a really short video that you can find online, and that's from Asthma and Lung UK. So that's the video that we tend to show parents and children when they're in clinic and they're being changed onto a MART regime. So when we changed, why do we change children onto the MART regime? So we know that obviously a dry powdered device is better for the environment. It doesn't have the gases that the meter dosed inhalers have, that we tend to start children on. But we also know that it's easier for children to carry. So definitely that's why we tend to do it around secondary school age. It's easier for children just to pop into their blazer pocket, and then we know that they've always got their inhaler with them. If we're seeing children and we know that maybe their adherence is not very good to their spacer and their inhaler, they don't like carrying their spacer around at school, then that's the time we would sometimes change them onto a MART regime as well. Obviously, the best inhaler that you can have is the one that you're going to take. So if you're on a meter dose inhaler and you're using it with a spacer and you're using it really well, then we leave alone and we don't tend to change children over, but we always give them the choice. So the benefits of MART is that we know that it reduces the risk of a severe asthma attack. And there's been lots of Cochrane studies done to look at actually if you've got a child who's got poor adherence to their asthma preventer inhaler, then actually going on to a combined inhaler will often work better, because actually as soon as they're symptomatic and as long as they can recognize those symptoms, as soon as they start taking that inhaler, they are getting some of those steroids, which we know that's the key to reducing that inflammation with asthma. It can also lead to improved adherence in medication. If children like that inhaler, they like not having to carry a spacer, and they like the fact that it's small and easier to transport everywhere. And then obviously if you're taking your inhaler, you've got better control of your asthma symptoms. When we compare air and MART regimes, really, when we're looking at air, it's kind of like children who don't get very many asthma symptoms and who can just take their inhaler when they've got symptoms. But if you're fine that if you're on an air regime, so it's the same inhaler, but if you're not taking that twice a day, and then you end up taking it more, so more than 7 or 8 times a week, then you need to go on to a MART regime where you're taking it twice a day. But for this webinar, we're just really going to concentrate on MART and taking your inhaler twice a day. So we look at the child and obviously make sure that it's suitable for them, and their suitability, that they are actually going to be, actually adherent to that medication. This is a case study of one 14-year-old who we have seen in clinic. So this child was seen in clinic. They were on Clinell, so that is a meter dose inhaler, and they were on 100 micrograms, 1 puff BD. So they're on, a moderate dose of Clinell. They were a known asthmatic. They'd been diagnosed with asthma, and they were using their salbutamol 2 times a week at that time. Their FeNO in clinic was 42, so we know that that is raised, and that shows that they have got some eosinophilic inflammation inside their lungs, but their spirometry was normal. So we often see that in clinic as well, that children they don't obstruct, and they don't come in with an obstructive picture. Sometimes they do, but usually they're not obstructed. This child had an asthma control test of a score of 11. So we know that anyone who scores below 19 is showing that their asthma isn't well controlled. So, and the reason that they scored so lowly on their ACT was because they were using their inhaler, their blue inhaler, so their short-acting beta antagonist inhaler. They were using twice a week, and they also were waking up at night with their asthma symptoms. We knew that their adherence wasn't very good. They didn't really like to take their inhaler, and they didn't like taking it to school. Their inhaler technique was quite poor. They were only taking their salbutamol via an MDI, so just the little inhaler without actually using a spacer, because they weren't carrying their spacer to school. And this is, we see this time and time again in clinic. And these are all of the things we look for in clinic. So we look at inhaler technique, adherence, and really get into grips with what the child is actually doing. So the clinic changes, we actually changed this child over onto a MART regime, so changed them onto a Symbicort inhaler. And to do that in clinic, what we tend to do with children is we do an in-check dial. So you can get an in-check dial from Clark Clements, and it's really easy to do. We can also, just to make sure they've got enough inspiratory strength to actually use a dry powdered device. But you can also, if you contact AstraZeneca, you can also get whistles. So you can get training whistles, which is really similar to these kind of like demo devices that you can get. But when your child, you get this child to actually use the device, so the whistle goes home with them. It's a one patient kind of use. So they can see if their inspiratory strength will actually make the device whistle, and if it does, they've got enough inspiratory strength to actually use it. So we then show them obviously the Turbohaler video, which I've showed you, and then we give them the personalized care plan, which I'll go through how we explain that to parents in a minute. Then if we're not a prescriber, we send a letter to the GP requesting that they start a Symbicort regime and prescribe a Symbicort inhaler. So let me go back to that. Hold on 1 second. The Symbicort Mild Asthma Action Plan. So when we're describing this and we're explaining this to children, we tend to use their peak flows, if we can do, if we've got them in clinic, and we just give them however many puffs they're taking. So the green controlled asthma side of this plan is obviously what they're taking every day. So usually we would start a child on 2 puffs twice a day, or maybe 1 puff twice a day. But for this regime, we'll say that they're going into 2 puffs twice a day. So they have 2 puffs in the morning, 2 puffs in the evening. And we say to them, this is when, your asthma is really well controlled, just on a normal day-to-day basis. Then we'll put in their peak flow, and we'll do it 75% in the orange section. And this is where, if their asthma is starting to play up, if they've noticed they've got symptoms or they may have a cough or a cold, this is what they can do. So they can still use the same device, and we always say to them, you don't need your blue inhaler anymore. You can put your blue inhaler away, you don't need it. You can just use this inhaler, and this is the only inhaler that you need now. But if you notice that you're getting symptoms, you can take one inhalation of this inhaler and then wait a few minutes and see if that works. The medicine in it works exactly the same way as the salbutamol, and it works within like definitely a few seconds. So leave it and just see. So we explained that, changing over onto a different inhaler just sometimes just takes a while just to get used to, but this will work when you are symptomatic as well. So you can take up to 8 inhalations in a day. So if you've taken 2 in the morning and you're due to take another 2 in the afternoon, so that's 4 inhalations. You've got another 4 inhalations that you can play with during the day if you're having symptoms, if you're having asthma symptoms. So usually a child wouldn't need any more than 8 inhalations. And what we say is, if you've taken 8 inhalations and you've used that regularly over a few days, that is the time that you need to go and see your asthma nurse or your GP, because that's showing that your asthma, something's triggering your asthma. So you need to go and see your healthcare provider just to make sure that everything's on track and everything's under control. If you're having an asthma attack and you've got severe asthma symptoms, you can take up to 6 puffs of this in one go. So you would take one puff, leave it a couple of minutes, then take another, and you can take up to 6 all in one go. If you found that then hasn't relieved your symptoms, then that's the time to ring 999. You're having an asthma attack and you need to go to hospital, and you can repeat another 6 puffs of this. So 12, we say basically 12 is the maximum that you should be taking on a daily basis. If you've taken 12 over 24 hours, then that's you going into an asthma attack, and you should definitely be going to hospital or to your GP. You definitely need an asthma review. But you can take 6 and another 6 if you're in an emergency situation. So we always say to parents and children to take a picture of their asthma inhaler, so they've got all of the information in one go and they know where it is on their smartphone. We also say to them to stick it up on the fridge so they've got a copy at home as well, and always share their asthma action plan with their school as well. On the other side of this, it's got an area where you can write down all of their triggers. So go through with them in clinic what their triggers are and what makes their asthma worse, and then also put down when they've had their annual asthma review, when their next one is due, and also the contact details. So where they can really find those details quickly of who they need to contact at the GP surgery or the practice nurse. So that's what we go through with the asthma action plan for the MART regime. So let me go through find out where I were. We were here, weren't we? So this was the follow-up from this case study. So this 14-year-old who we've changed over to Symbicort. So now we do an ACT when they come back to clinic, and their ACT is 20, which is just kind of like in the remit that they're actually fine, that their asthma is well controlled. So we know that those asthma symptoms, though, using that the salbutamol or using a short-acting beta antagonist has really, so how many times are they using this Symbicort? How many times have they had to actually use those rescue breaths of that Symbicort? That's what you want to find out. Their FeNO was actually much better. It was actually 20 again, so in clinic, so we know that that's reduced and that's gone down to normal levels of the eosinophilic inflammation in their airways. Their symptoms were much better. They had no nocturnal symptoms and they were no longer coughing. And they were also able to walk up the stairs at school. And this is what sometimes we see in clinic, that actually children aren't aware. They've got used to those asthma symptoms. They've got used to struggling up the stairs and being out of breath when they've reached the top of the stairs. But actually starting that asthma treatment, and a treatment that they are actually going to adhere to, is actually relieve those symptoms that they didn't even mention before. So MART does support the current guidelines. The current guidelines that really are in tune with MART and AIR are the GINA guidelines, but the new guidelines that are coming out later on this year, the BTS sign guidelines that are being finished as we speak, I think will have MART as well, or they will have MART as well on there. So conclusion, really, change over, obviously use your clinical discretion when you're changing children over onto this MART regime, but we are seeing a tremendous, children like this regime, especially when they're going into secondary school. But obviously it's on an individual basis, and really the most important and the best inhaler that you can have is the one that your patient's going to take. So thanks for listening, and take care.